So welcome. I'd like to take the opportunity to have each of you introduce yourselves and tell us a little bit about what you do.
Hi, I'm Laura Schlenker. I work for Cerner Corporation in the Quality and Patient Safety Division. So related to sepsis, what I do is help make sure that we match the technology, the alerting, and the clinical processes so it's most effective.
Great, thank you.
Good morning. My name is Richard Smith. I'm an infectious disease specialist. Mainly my role is at a private hospital at Tri-City Medical Center in Oceanside, just providing consultant expertise work there.
Thanks.
Hi, good morning. My name is Hildy Schell-Chaple. I'm a clinical nurse specialist at the University of California, San Francisco Medical Center. And on a daily basis, I work with the interprofessional teams in our critical care units to ensure patients get safe and high quality care. I have a big role in clinical leadership and being on teams to translate evidence into practice. So all those bundles that Anna talked about are online. The hard work is implementing them into the various systems and workplaces that we have, but we need to use, using different models. So I was on our sepsis initiative team, and we'll share more with that.
Good morning. My name is Kayla Renals. I work for the Centers for Medicare and Medicaid Services on an innovation model called the Partnership for Patients. And perhaps I'll just explain what that is for those who may not be familiar. The Partnership for Patients is an Affordable Care Act funded model test out of the Innovation Center that's aimed to reduce the time between clinical practice in publish and clinical practice in practice. So various studies have shown that that gap is about 17 years long. And our aim is to reduce that dramatically. And we did so by funding 26 hospital engagement networks throughout the entire country, which represented about 3,700 hospitals, which is 70% of all the acute care medical centers in the United States and about 80% of all admissions. So all admissions, not just Medicare and Medicaid, this is all payer data. And we're very proud of our results. Some of them were mentioned the other day, the 17% reduction in hospital-acquired conditions and harm, 50,000 lives saved, 1.3 million adverse events avoided, and almost $12 billion in costs. And I should say that those results are not just the Partnership for Patients. That's the result of what we were talking about yesterday, these large public-private partnerships. And many of our partners are actually here in this room, Kaiser Permanente, the March of Dimes, ACOG, and many, many more. So just another example of how working together can really be dramatically results.
Good morning. I'm Chris Fee. I'm an associate professor of emergency medicine at University of California, San Francisco with Hildy. I'm also the residency director there for the emergency medicine program. I've had a long-standing interest in quality and patient safety. I've worked with our department to improve care to patients admitted with pneumonia, hand hygiene projects. But perhaps the most influential work that we've been a part of in our institution is the work related to sepsis and early detection.
So we do have the opportunity to take your questions. I'm going to start with a few questions with the panel, and then we'll open it up to the questions you've submitted. So Chris, I wanted to start with you. Can you share a little bit of the lessons learned that you gained from your initial attempts at implementation of your sepsis surveillance system within your emergency department?
Yeah, I think kind of piggybacking on what Kayla's mentioning, the original trials looking at the sepsis bundles, the proof of the dramatic impact they could have came out in an article from 2001. Here we are in 2015 talking about why we aren't all doing this. Yes, there's been controversies around some of the bundle aspects, et cetera. The challenge for us early on, 2002, 2003, when I first became faculty, was not so much teaching people what to do. It was really how do you identify the patients that needed the proper care and early on in the course. So identification was a big piece of it. The other piece of it was really how do we get the emergency team, the physicians, the nurses, the pharmacists, the techs, et cetera, to work together in our unit, but also with the ICU. And so we had a collaborative process where actually all those groups got together. And the intent being, let's identify these patients, let's work as a team. At the time, our bundle included placing central lines, et cetera. And it failed miserably. Why did it fail? I think part of it was around perhaps lack of critical attention to the ongoing. Somebody mentioned yesterday, you can put a policy in play, but unless somebody's watching it and providing continuous feedback and continuous performance metrics behind it, it's meaningless. What happened in 2013 or 2012, sorry, the emergency department in our institution had a homegrown electronic health record. That record, because it was homegrown, was very limited in that it was essentially a database where the physicians could type their note, the triage vital signs were put in there, but there was no computerized order entry, there was no nursing notes as part of it, there were no updated vital signs as part of it. Our group, together with support from the leadership of the institution, nursing, pharmacy, our quality improvement folks, et cetera, we developed a very rudimentary screen in that protocol that looked at the vital signs at triage, and if enough of them were abnormal, it would flag an alert to the triage nurse saying, hey, this person may be sicker than you think, and it would print out a sheet, and when the physician opened the chart, the same thing would happen. It was a little bit of a tap on the shoulder, just as a reminder. And it's not rocket science. Abnormal vital signs should catch your attention anyway. But in a hectic, chaotic environment where we're in, where you're getting phone calls, handed an EKG, a sicker patient arrives, or seemingly sicker patient arrives, the constant interruptions lead to human systems failure. And we were missing patients early on. The problem with that system was that only had the triage vitals. It didn't have subsequent vitals. So if your vital signs were normal at triage, only to become abnormal an hour later, it wouldn't flag. So it took the institution purchasing and implementing a much more robust electronic health system that allowed us to build upon what we learned from this, but then really get much more deep and much more valuable information. So the current system now trolls, if you will, vital signs continuously as well as lab values in the background. And anytime those things come up as abnormal, everyone in the department gets alerted. So we know the second that somebody meets the criteria.
That's incredible. That's an incredible advancement. Hildy, tell us a little bit about what was instrumental in the implementation and the extension of the work that was done in the ED within the acute care side of your organization. As you experienced, you were right there in the thick of it, and you experienced quite a bit of in that process of implementation. Can you share what you learned about that with us?
Yeah, so as Chris mentioned, I remember us all actually going to dinner in 2002 or 3 and saying, hey, let's do this. Just got our critical care and emergency department team together. And well-intended, but just there was no structure or support and meaningful support from administration at the time. It wasn't on the strategic plan. It is today. So 2 years ago, when we implemented our electronic health system, we got the support. It's on our strategic plan. Our quality department provided the leadership that needed to pull our team together. And not just clinicians. Our informatics specialists and analysts are essential in terms of these algorithms that have been developed and then optimized over time, and the testing that goes involved with surveilling, again, not just vital sign data, but lab data that would take me 3 to 10 clicks to get into a record if I was thinking about checking all of those things, to other clinical nursing assessments that are in the record. So we looked at workflows as well as the culture of the units. We started out with pilot units, 2 of our medical surgical units, 1 of the intensive care units in the emergency department, because everyone wanted to do it, but we wanted to optimize the surveillance as well as the implementation bundle. So early detection's great, but to achieve the successful outcomes, you have to have early appropriate interventions as well, those bundle of care elements. So our pharmacy colleagues, for early detection, let's say obtaining a lab sample of lactate, which is a lab value that can tell us about hyperperfusion. I mean, someone actually may have a very normal blood pressure, but their organs aren't getting the oxygen they need, and this lab test can tell us that. Well, someone has to think, is this patient at risk? Should I draw it? I have to call a physician, get an order. So we implemented a protocol approved by our medical board, and these are systems for the leaders in the room to say, can nurses do this based on protocols If the patient alerts that they're having abnormal vital signs, and we think they may have an infection, that I can go ahead and draw that lab without having to call a physician. So early time is of essence. Get that result back to say, oh yes, we are in need of further interventions. So that's one systems change we made that was essential in early detection. Also then, so how do we get the team to the bedside in the right care? Our pharmacy colleagues access to antibiotics. For every hour delay in getting antibiotics, we have evidence that shows mortality just increases incrementally. So easy for the provider, physician, or nurse practitioner to write to give 2 antibiotics. The time to get those antibiotics to the patient is essential. So we, our pharmacy colleagues created a reference for that provider to say, these are the 2 options. If they have allergies, use this one. If their weight is this, use this one. So it's all there as a reference for them. All those medications, first dose antibiotics, are on all of our units in our med stations available, so they don't have to go down to the basement, 13 floors, and have it sent up and maybe lost in transit. So those seem like simple things, but essential to getting those therapies to our patients. We also, our electronic system, the severity of the sepsis as it increases can alert if organ systems are involved, what we call a code sepsis. So the physician, when they open the record, will see, oh, code sepsis, or the nurse, and say, let's activate this team. Let's bring those experts to that patient's bedside, whether they're on the medical surgical floor, the transplant floor, or in the ICU, and a nurse practitioner from critical care, a registered nurse on a rapid response team, and a pharmacist, come to the patient and help facilitate that process, rather than a team that maybe, on the neuro floor, they see sepsis a couple times a year or month versus other units. So you bring the expertise to the bedside to get that early interventions and appropriate care. But it's the workflows, the culture of the unit, and culture change is hard, but using kind of culture of safety and teamwork are where we're moving to, and have really provided education to the staff to say, this is as urgent as that neuro change and code stroke, or as urgent as the chest pain, and maybe this is a cardiac event. Mm-hmm. So it's people will value and do the move to do the right thing if they understand this is something that if we do detect early, intervene early, we can optimize our patients' outcomes.
That's great. One of the challenges sometimes is that interface between the ED and the transfer over to critical care. How have you addressed that within your organization?
On handoff, we know whether the sepsis button, RED is awesome. Their compliance and, with implementing the bundles is really, it's a 99, 100%. So it's a part of handoff where the bundle's done. So by the time they get to us, it's like everything's really been done, but that really is on our checklist for handoff from ED or even from acute care, because that's, someone decompensates out on the ward, and the nurses weren't able to get the blood cultures yet. It's like, that's what, we need to get done right when they get to the ICU, so we have that bundle element taken care of.
I think the other key piece to that is that having representation from each of those groups on the leadership team for this. So it was myself, Hildy, the director of the ICU involved. There were inpatient medical personnel, both from nursing and the physician leadership side, all on the steering committee for putting this together. So everybody got on the same page, but it's one thing to have the leadership on the same page, but how do you disseminate that information? I can tell you from the emergency department side, yeah, it's easy to flip the switch on the computer and make the screen go live. Mm-hmm. That was the easy part. People keep referring to this as not being or more challenging than rocket science. No, not for this. This solution is easy. We're looking for data that's already out there. We're not creating a new drug. We're not, it's looking for data that's there. The hard part, I think, really is the culture change and and understanding why this is important. So, we are really fortunate where we work that our quality personnel get very timely feedback to me, to Hildy, to our ICU physician side, to the inpatient medicine side. Anytime there's a case that is not meeting compliance, from the ED perspective, I'll get that data within a week. I will look through the chart and send the providers an email and say, what happened here? Not as a finger point, not as, hey, you messed up. Where did the system fail? And so just by doing that, the old, if you watch, they will change their behavior, that is equally or more important than the screen itself. It's just letting people know that you're watching them and that you're trying to help them improve the care. So I think that part is the culture change part that is incredibly important. That has to happen throughout the institution. It has to be supported by the leadership of the medical center, and we're incredibly fortunate that our CMO and other leadership folks have taken this on as a priority. Otherwise, you're not going to make meaningful change, long-lasting change.
The continuous process improvement, I mean, we all assume that's being done, but that feedback, what is our compliance with the bundle, what are our outcomes, and seeing that, and sustaining this. We've had success. Our compliance in our bundles when we went live from 2012 to 2014 was 30% compliance with the intervention bundles, and is up to 2 years later, 83%. And our mortality during that time in our patients with sepsis declined from 18% to 12%. Now, that was at 2014. We're seeing a little creep, so now the hard work is sustaining this with the data now that we've gone from those pilot units to all of the adult ICUs and acute care wards. It is a sustaining and getting out and changing the culture now in 20 other units. We spent 2 years in 4 areas. We need to help get these other units to sustain that change.
Richard, tell us a little bit about the work you've done in your organization. Are there parallels between what we've heard from our other colleagues?
Yeah, I mean, I thank you for sharing your story, and I can totally identify with that. I mean, we see it a lot where communication is the key, basically. And if you have an infectious disease specialist at your hospital, take advantage of it. It's not a burden. If you call, if you ask questions, if somebody's not turning around, keep an open mind too. I'll tell you a story. At one of the hospitals that I see in North County of San Diego, they have sepsis protocol. The bundles, they check off everything, and the patient goes to the ICU, but the patient's not improving. So what's going on? At that moment is when usually an alarm goes off, and ICU doctors, and they bring people in to see the patient, somebody that can try and figure out what's going on. One of the things that we had a problem with was necrotizing fasciitis. When I started private practice, there weren't any bundle order sets for necrotizing fasciitis. In fact, we had a couple of patients die at a couple of our facilities because of the lack of moving forward. We went in, we saw the patient, recognized that there was a limb that was not looking good and probably was necrotizing fasciitis. And this is a deep tissue infection with a high mortality rate, usually caused by group A streptococcus. And the therapy, the treatment of choice is antimicrobial support and usually surgery. You have to go in there and debride the tissue that it's being infected or dying. And a lot of our surgeons were not willing to do that. They look at the extremity and they'd say, I don't see anything there. And we were not fine with that. So we went to another surgeon, and the other surgeon in the middle of the night said, no, I'm not coming in. It doesn't sound like a necrotizing fasciitis. Well, we had a couple of those patients die, and it took that for the rest of the physicians to come together and try to come up with some rules or some orders that would be set in motion when a patient comes in with the suspected diagnosis of necrotizing fasciitis. Then you have to have a plastic surgeon see the patient, you have to have an orthopedic surgeon see the patient, critical care physician, and an infectious disease physician. And we had really good success with that. But it unfortunately takes something to go wrong for us to set those things in motion. But things are getting better.
Thanks for sharing that. So that's a bit of a wake-up call, isn't it? Julia, you did such a beautiful job with sharing your story in the video, so thank you for that and for your comments afterwards. When you're hearing some of the stories and the comments of the work that's going on from our colleagues here, how does that resonate with you as someone that's lived it in ways that we hope others won't need to?
I think I'd like to start by pointing out that it's significant that I'm sitting on a panel with 2 providers from UCSF where my daughter was injured, and that's just something that wouldn't have happened in the past in and of itself. When I have gone to UCSF in the recent past, I'm now welcomed with open arms. People want to hear what I have to say. There really is this spirit of collaboration and of having an open door policy to patients. I think to your story, that was our story. The pediatric intensivist saved my daughter's life. There's no doubt that their skill, we had an infectious disease doctor there that night. Her antibiotics were started quickly, correctly. So from that aspect, everything went well. She did start to initially improve from those therapies, but of course, because of the underlying infection, she started to go downhill quickly after that. And what I feel was a big part of that was the hierarchy issue, and that is a huge issue. It's part of culture, but it really is kind of its own issue as well. When the intensivist called in the orthopedic surgeon, he made a very quick, I thought kind of rash decision that the wound didn't look bad. Her leg looked okay to him. There's no way this was an infection, and he left. And when I had a very revealing conversation with Dr. Fee last night asking, how something like that can happen, and could that still happen? And I think the answer is yes, because we haven't worked on those hierarchy issues the way that we need to. What I hear and kind of confirmed by Dr. Fee is if you have pediatric in front of your title, you're a little bit lower on that hierarchy scale than somebody who's a surgeon. And you will likely tend to defer to them. And you may not have a system in place at your organization to bypass that. And that's what I was asking 15 years ago. I couldn't believe that one provider could stall the whole process that way. But that was exactly what happened. So I think that's another issue, the teamwork, the collaboration, and this hierarchy issue. It's not a team if one person is always pulling rank and able to completely stop progress.
So that notion of complete collaboration and working together against some of these authority gradients that you're describing is critical. I mean, I'm sure we all experience that every day. Kayla, tell us a little bit about the work that you're doing with Partnership for Patients and your HENS, and does some of what you're hearing today resonate with the work that you've seen nationally?
Oh, absolutely, yes. So I should say, originally, you have the Partnership for Patients focused on these original 10 areas of harm, like adverse drug events, CAUTIs, CLABSIs, things like that. A lot of the evidence has been out there for years, and it has been adopted by many people. That's different than sepsis, where bundles do exist from the Society for Critical Care Medicine and others. Not widely implemented, not as widely known, I should say. And so when we went to sort of address this with the Partnership for Patients, what we did was we had a competition with our HENS, offered them additional resources to add sepsis and a host of other topics onto their statement of work. And instead of recommending that they follow the Surviving Sepsis campaign or anything like that, that's not our role as Medicare. We're traditionally payers. We leave that to the CDC. And we empower, or we ask the hospital engagement networks to assess the needs of their hospitals and their networks, because no two are alike. One might have an excellent culture. One might have a not so good culture. One might need infrastructure help. A whole host of issues. So that provides some flexibility for them to sort of determine what their needs are. And the HENS that we chose, there were 6 of them that were awarded this additional funding. They all, ironically, chose the Surviving Sepsis campaign to implement. So they tracked process and outcome measures from the 3 and 6 hour bundles. There were 73 pilot sites across the country that included quite a few rural and critical access hospitals, we're proud to say. And they had some really, really fantastic results. I'll just name 2 of them. I won't rattle through all the statistics for you, but Carolina's healthcare system experienced a 35% reduction in mortality in their emergency department. And this is not a 3-year period of performance. This is a 15-month period of performance. Washington State Hospital Association, a 38% reduction in mortality hospital-wide in sepsis. So it is possible. We know that these things are possible. But to Julia's point, there are things that are possible when you bring patients into the conversation. Patients should absolutely be part of a sepsis diagnosis and treatment because they're the first ones who notice when their loved ones are decompensating. Not, the doctors may recognize it, but the patient and the family members know each other the best. So through collaboration with people like Julia, who has participated in the Partnership for Patients, and Alicia Cole, I know she's here somewhere, I encourage you to meet both of these people. Hi, Alicia. They're really, really inspiring, and just call to action is just so important to them, and it's been very helpful to our partnership, I would say.
That's great. So that's pretty incredible improvement in a pretty short period of time. Was that collaboration with the voice of the patient and that partnership, do you think that was fundamental to shifting, to achieving that kind of accelerated improvement?
I do. I think there's a number of things that were really helpful. Certainly collaborating with patient advocates like Julia and Alicia and others. But there were a number of lessons that the Hens learned that really helped them because sepsis was just one topic in a list of 22 that they were working on. So when you think of all the bundles that entails, you're talking about quite a few of them. And so one of their lessons learned was to identify areas of overlap or efficiency between each of them and really have command of what tests can be used for more than one purpose, what data can be used for more than one purpose. That would be the first. The second, and I'll just tell a little bit of a story from Ascension Health, another one of our Hens in this project. They recognized that their community onset sepsis far outweighed their hospital-acquired sepsis, which is what we had asked them to focus on originally. So in the standard CMS contracting world, technically they had fulfilled what they had proposed to do originally, but they didn't stop there because that's not what's important to the patient. To the patient, for patient safety, you're going to do whatever it takes to make that environment safe for your patients. And so they changed their approach. They said, okay, instead of looking just at hospital acquired, let's go out into the community. And so they started to reach out and figure out where these community onset cases were coming from. Was it home health? Was it nursing? Was it skilled nursing facilities, nursing homes? And so they started to get partnerships with all of those people in the community and bring them into educational events, figuring out how to collect some data with them, and they found that was really successful. Great. And then I would say the third sort of challenge that we had, and it still continues to be an area of improvement, and I know that this is a very academic setting that this may engender some conversation about later, measurement. Measuring sepsis. How does one measure sepsis? The definition of sepsis is still so, it's not static. Not everybody agrees on what sepsis is and how to measure it. So there is still no nationally recognized, adopted standard measure for sepsis. And I think that's an area of opportunity for all of us to work on in the future. And certainly we'd like to be a part of that.
Right, that sounds like our next challenge. Mm-hmm. Laura, tell us a little bit about the work you're doing within your company to support all these initiatives around getting to zero on sepsis mortality. Tell us what you're doing and how you're leveraging the IT world to get to some of the outcomes that we're looking for.
So for anybody who doesn't know, Cerner is one of the EMR, it's electronic medical record companies, and I work in the quality and patient safety. And the thing that we have found, and many of you have found, is how do you remove that person error, that thing that we can't always control, the nurse that gets interrupted when the tech is telling them the vitals, the physician that got called in the middle of the night and the nurse wasn't able to give a good definition other than, I don't know, something's not right. How do we give people the data and the information early enough to make a good decision of what to do? So what we have done is we're on our 14th version of Sepsis. So it's basically an algorithm that runs behind the scenes. So every time someone enters a piece of data into the system, this algorithm runs. So if you have a tech that's entering vitals in another room, if labs finally post to the system, as soon as that piece of data is entered, then it's immediately will trigger an alert to the healthcare provider. Where one of the gaps in one of my roles is to connect that dot, because a lot of hospitals have sepsis alerting or sepsis identification, but most of them do severe sepsis or septic shock. They're not able to identify at the state of SIRS or just early sepsis. And we know that once they start the cascade of actually moving into sepsis, it moves very quickly. And once you hit severe sepsis and septic shock, you may not be able to get them back, especially not back to baseline. In addition to the sepsis alerting for SIRS and early sepsis, we also we have MUSE criteria, so modified early warning. And we've been working with Intermountain on a partnership, and they've actually last year published an article in JAMA on an early predictor of deterioration, which takes the MUSE and adds oxygenation to that, and they've had greater specificity and sensitivity with that. What that does is it takes your patient that's been on the floor for a period of time, that they were progressing with treatment, they're doing well, and it watches for those minute changes in vital signs and symptomology, where a very good example is your patient that has an aspiration pneumonia. What you see is their MUSE score will tack along, and when that event happens, their MUSE score immediately climbs a lot higher. And you catch that early warning before we have even gotten close to sepsis. What you'd find is their MUSE, well, we start treating or seeing them start to stable off a little bit, and then we have a sepsis alert fire. You can actually have a warning that this patient is sick 5, 6, 8 hours prior to them even starting down the sepsis cascade. So by using those in conjunction, you can prevent failure to rescues, you can prevent ending up in the ICU altogether because you were alerted much earlier to that event. The problem is that when we talk to providers and we talk to nurses about sepsis, oftentimes they have this picture in their head of what sepsis looks like. And so they're resistant to this early alerting, well, like patient's not sick. Well, that patient isn't in septic shock, correct. What we're trying to prevent is ever reaching that state so that we don't have them all the way down that cascade, moved to the ICU, and have those extended patient stays.
That's great. So with those kind of early warning systems and the alarms that are associated with that, how do you deal with the notion of alarm fatigue or alert fatigue? What have you heard from your clinicians around that, and how have you addressed that?
That's actually something we work very hard with. So a very good example is you really don't want to get alerts on a patient that is a comfort measures or a hospice patient. You want to let the family be with them, give them those comfort care, but we don't need to be doing a ton of alerting. So we have what's called suppression criteria that we build in according to the actions that the clinician takes. So if you get a sepsis alert, the first thing we do is we direct the nurse to go assess the patient. When they come back and they document that they assessed the patient and contacted the physician, that'll automatically suppress the alert, and we set the criteria according to the client that we're working with at the time. The part that's really great about that is if I'm calling you because I want you to put the orders in, I'm going to document, I talked to Dr. So-and-so, I'm going to do whatever, and when I document that, it only suppresses it for an hour. And the reason is it gives you plenty of time to go back and look at the record, put in the order set in the bundle, which we actually have supporting order sets and things for that piece as well, to make sure that if you are the rural surgeon who's covering the emergency department and don't admit for sepsis, that you have all of the criteria there so it fills in automatically for you. But by putting those pieces in place, then as soon as you put that order set in place, then it stops that alerting for 12 hours. It lets that patient have the chance to get better or see what they're moving forward with in their progress of their care. But it still comes back online and will alert if they get sicker so that we don't lose them in the process of the care going forward.
That's great. So you both talked about how technology has really given you that next step and how it's resulted in fundamentally different improvement and actions than you might have done the first time you tried to implement the sepsis bundle. How is all that effort coming together now for you? And I'm not sure if you have that same system, but do your clinician experience that concept of alarm fatigue or just too much data coming at you? And how are you using that technology as an accelerator for your organization?
I can speak from the emergency department side. Certainly there, early on, I mean, I have a couple stories about it. We don't use the same system, but have a lot of the same ideas. We have suppression criteria, et cetera, to lock out. Mm-hmm. So if a provider says this is not from an infection, the person's still sick, but not from an infection, it'll lock out in the ER for 4 hours because our time window is hopefully shorter than up on the unit. But I want to share a couple stories from early experiences in this where I had providers come to me and say, hey, Chris, that stupid thing went off again. and this patient did not meet criteria, SIRS criteria. We also have a 2-stage thing. I would go back and look into the record and go, well, actually, right there, they had a fever, and 2 hours later, they became tachycardic and their white blood cell came back. And I share that story because I think it points out the fact that here was a provider at the bedside with the patient. The alert went off, and they didn't believe it. They assumed it was an error, a technological error, and came to me with it. And it highlights how difficult it is to think of patients as being sick when they might not look sick. So getting that information early before, I agree with you, before they become blatantly hypotensive and
Right.
on the edge of that precipice from which you're not going to get them back. So we had a few of those kind of cases early on, and again, the feedback to those providers, taught them that, oh, you know what, you're right, these people are sicker than I think. And so I think we have to remember that patients can be very ill and look quite well. That's one thing. I think the other lesson that we learned early on, before we moved from what initially was an emergency department system to implementing it in the units and then the wards upstairs, we had it running in the background that wasn't available to clinicians on the floor. Basically trying to work out some of the bugs, see how frequently it was going to go off and that sort of thing. At the same time, the pilot units already had paper screens that the nurses were doing twice a day. They already had a protocol in place for when to call a code sepsis, et cetera. We sort of preliminarily have looked at this and looked at when a code sepsis was called. What was time 0 for the code sepsis? Hey, let's go back and look at the screen that was running in the background to see how much earlier it would have been. And there were cases that were 17 hours earlier, 24 hours earlier. So these are patients who are being watched closely. Again, look well, but have data that's coming in that is just, because our workplace is chaotic, is being, slipping through the cracks. And so I think that does speak to the power of having a system that can do the work for you. Initially, maybe give you a tap on the shoulder and later hit you in the head with a 2x4 saying, hey, dummy, you're missing something.
So that's a cultural shift, isn't it, to trust the technology in that way?
It is. I just want to shout out to not just our informatics team, but that level of work behind the scenes, that they do that mapping and reassessing, and then working with the clinicians to say, well, this population, so we have a big liver transplant program, a big liver failure population, and they tend to run low blood pressures baseline. So in that population, how are we going to identify, that patient population, and not by a diagnostic code, but we have other, sophisticated ways we figure out how do we identify that code so that the alert is different in that population. Okay, and the complexity of sepsis syndrome is that not everyone presents the same way. When my son had sepsis, he never had a white count that was abnormal. Some patients don't have fever. 10% of patients with severe sepsis have hypothermia. So it's very complex. And this technology intervention, the surveillance, I think we've all been surprised with how much it's changed our practice and the outcomes, but it's an adjunct to the clinical exam because sometimes patients look worse, but their numbers don't. So there's both sides of that. It is an adjunct and to be used with our clinical exam. And it doesn't mean because we have the surveillance that people don't need to understand sepsis and its complexities. So we still need to continue with our education and training about how to use this well and in addition to our clinical exams.
Richard, are you experiencing any of those kind of challenges in your organization with the notion of learning to trust the technology and the guidance that it's giving you? And
Yeah, I think it's a huge plus having electronic medical records. I mean, we're living this. When I went to school, and we didn't have that. I mean, I trained in Atlanta at Emory there. At the VA hospital, they were the ones that were sophisticated and had the first kind of electronic medical records. But it's been a steady learning curve for me, and there's still a lot of room for improvement. But I work with infection control very closely at our facilities, and it helps us keep an eye on certain things. And Certainly measuring things is easier, and the data you can get that more readily than before. So it's a huge plus for us. Just looking into when the patient comes in. I know antibiotics are great and everything, but we also have the problem in over prescribing antibiotics, which is a huge problem in the majority of our facilities. But we can track who's prescribing what and for what reason, and not to go and punish that person, but just to have feedback. Right. It's something that we're dedicated in doing now.
Yeah. So I heard both you and Chris talk about the importance of giving that feedback to the clinicians and using that information to help increase awareness and drive change. And how else is that notion of feedback mechanisms helping in some of the other areas? With your IT, I mean, in the development process, I'm sure you're beginning to identify more improvements, or how do you really potentiate that technology? How is that, how are you addressing that within your organization?
The biggest piece that I'm seeing is making sure that we have the data to give back the real story. Mm-hmm. One of the things that I heard you say was, in order for them to believe it, having the specificity and sensitivity. We run with a sensitivity of 86%, but a specificity of 96%. And when you tell a physician it's 96%, they take that seriously. So I'm not going to over alert you. If you get alerted, this patient is truly sick or getting sick. And then being able to say, this is the number of alerts that we've triggered. This is where that patient fit. This is how sick they were. Being able to see this is what, and then being able for the performance improvement side to follow up with the provider groups and say, when these alerts are firing, it's taking 3 to 4 hours to get order sets started. Going back and looking at the data instead of we're getting it started within the hour. Mm-hmm. And so it's being able to tell that story and give that feedback with hard data of what they actually did, not, well, in the nation, because we're different. Everybody's different. We all want to be different, but really the story is always told with the data. Mm-hmm. And it helps back up and change that adoption and that culture that we need, where people actually believe the computer instead of blaming the computer. They believe the alerts when they come up, and then continuing to do our due diligence behind the scenes to keep the algorithms correct and the order sets up to date and all of the research behind the scenes.
That's great. Kayla, tell us a little bit more in the Partnership for Patients and in the HEN. How are you spreading the knowledge that's being gained from some of those individual networks across a broader audience?
Mm-hmm. That's a great question. Actually, it was part of their mandate when they received this additional funding that they were going to do these small tests of change within their pilot sites and then spread what they had learned to the larger Partnership for Patients of 3,700 hospitals. And we do that through a variety of means. Webinars, a lot of them convene in-person meetings within government regulations, of course. And really talking about lifting up those examples of success, like our colleagues here, talking about from the front line, what do I do as a nurse, what do I do as a doctor to really drive home the message at my hospital? It's a lot of education, it's a lot of conversation, especially about what sepsis is, how do I identify it, how do I measure it, which I confess, as I said, is still sort of an ongoing conversation. But we're very proud to say by the end of the period of performance in December of this past year, we had 1,230 hospitals reporting data on sepsis to our evaluation contractor, which is quite possibly the largest amount of data we've ever had on sepsis nationwide. So we're very excited about that.
That's great. So when you have that much information and that much data, churning that data into information to drive change is a challenge. How do you anticipate being able to do that in this next round?
Well, I'm limited on what I can say about that, but I will say the Partnership for Patients evaluation is ongoing. We expect to have a final evaluation report by the fall of this coming year. So we want to drill down into this question of not only how effective were these interventions on sepsis, but this question about attribution as a whole. Partnership for Patients is this very, very large program. And it's been pointed out to us many, many times that scientific analysis would want us to have a control group, right? So how do you know and compare? This is all publicly posted on the Innovation Center website if you're interested in reading a 100-page report on our evaluation. But we actually did try to find a control group for this work, and we found a 26% contamination rate in that control group. where people cited the Partnership for Patients as a driving factor behind their quality improvement work. So we're still sort of working through the details, and we hope to have more by next year. But I will say, to earlier points about how data can be used to drive change, on some level, our evaluation is really a sort of a policy decision. And the results of our evaluation will certainly inform future acts of the agency. But from the hospital level and from the hospital engagement network level, providing that feedback to physicians and hospital administrators has been invaluable. Most of them have no idea, what their rate of sepsis is or what their rate of C. diff is. Some of them may if their administrators are very motivated and into this stuff, but your average rural hospital, they may not be measuring their cases of sepsis. So providing real-time data, actionable data to people who can make a difference in patients' lives has been really, really the catalyst behind a lot of change that we see. And a lot of our hospital engagement networks were doing that on a monthly or even weekly basis, providing them dashboards, run charts, control charts, and we found that to be very successful.
And I'm sure that support's critical for organizations that may not have the resources, like the resources I've heard from some of us on the panel, to really execute that kind of improvement. So that's wonderful that you're supporting them in that way. Julie, I wanted to hear a little bit more about your coalition for empowered patients. Tell us a little bit about the work you're doing within that coalition and how you're leveraging your experience to make change in that area.
Well, our work centers on patient education, which is really still in its infancy. I'm hearing all of this today, and it's absolutely phenomenal. I still think that we need patients to be more educated. I think sepsis might not have even been on the public's radar screen until recently. They have no idea that an infection can be that virulent or life-threatening. They think that you get an infection in your surgical site, maybe you take a couple of days of antibiotics and you're better. So certainly engaging our patients and families, which is the work that we try and do, to give them basic information, that foundation, that jumping off point. So when they find themselves in a serious situation or even just at a regular office visit, where is my starting point? What can I say? What can I do? What are the actual words that I use? What we heard from families is telling me to speak up or to participate is not very helpful. I would like you to give me the exact words I should use, and what do I do with that information, and how will my providers respond? Are they going to be upset at me? Are they going to be angry? Am I going to be that problem patient? Our patients still worry about that. I think as a physician, one of the scariest things I could hear from a patient or a family would be, something just isn't right. I don't want patients and families to discount their gift of intuition, to realize that they're the experts on the patient. And they don't make that leap without some sort of also data and facts. You're looking at the alerts and believing them. The family has alerts, and they discount those alerts just like the providers do. And we don't want that to happen.
So we're going to wrap it up. I want to thank the panel for sharing your thoughts, and I believe we have another video we're going to show. So we're going to sit back and enjoy that.